Greetings, this is Miss Gibson. So this is alterations in voiding patterns and inflammatory and infectious urinary disorders. So this just talks about some of the objectives. I'm not going to read that to you. Urinary retention. So we know that this is just incomplete emptying of the bladder. It leads to distended bladder, inability to urinate. We know that if we have a patient that has this retention, it can lead to UTIs, several different things. So some of those tests that was discussed in the first lecture would be ordered. Let's see, some of the causes of retention can be a mechanical bladder obstruction with your male patients. It could be that BPH, which is your benign prostate hypertrophy. That's just where the prostate is enlarged. You could have acute inflammation of the urinary tract due to a kidney infection. Everything is just inflamed and swollen. Could have some scarring for your patients that have chronic UTIs. And then also you could have an obstruction due to bladder stones. So if you have a stone that is blocking your ureter or maybe your urethral opening, that can cause retention as well. A functional problem, this could be from abdominal or pelvic surgery, which disrupts function of the muscles. Could be some of your drugs, your anticholinergic drugs, antihistamines. You could have some voluntary urinary retention, which can lead to loss of muscle tone. Some of the clinical manifestations are overflow voiding or incontinence, firm distended bladder, which you can sometimes feel over that the bladder area. Severe urinary retention causes backflow of urine into the ureters and or kidneys, which can lead to some impaired renal function. If you've ever heard of hydronephrosis, all that means is there is a backup of urine that's coming back up into the kidneys, and it can be very painful. The docs will do a assessment where they kind of tap your lower back, left or right side, and if there's rebound tenderness, generally they'll go ahead and order some more tests to test for hydronephrosis. They'll do a bladder scan, which is just this machine that they run a probe over your bladder area, and it tells you on the screen how much urine is in the bladder. A lot of times in a hospital setting, if the patient comes in and the bladder scan shows that they have 700-800 mLs of urine, we will do a straight cath. Or we might do a post-void residual to see, have them void if they can, and see how much is left in the bladder. We've already talked about this, just some things that would cause it. Your medications, may have to do a catheter, fix any obstructions, especially if they've had a stone or something like that. Positioning can also help. You want to promote the voiding in a comfortable, normal position. If they have to use a bedpan, don't leave them laying down. If you have to do a catheter, make sure you do some good education on catheter care. That's very important. There's also things that you can do education on, like double voiding, where you'll have your patient to void. They'll sit on the toilet for, a couple minutes to 5 minutes and then see if they can void again. A lot of times they can't just because of whatever is causing this urinary retention. Next, you have a neurogenic bladder. This is loss of voluntary voiding control resulting in that urine retention and or incontinence. It's just pretty much where the bladder is filling, but it's not really emptying. So bladder filling and emptying is controlled by your central nervous system. Any disruption of your central nervous system or your peripheral nervous system can interfere with this. So you'll have you could have like a spastic bladder dysfunction, which is an overactive bladder. You see that a lot in women. They'll be incontinent. It is caused by disruption of your nervous system, disruption of your central nervous system transmission above the sacral cord level. Frequent spontaneous contractions of the muscles occur along the involuntary bladder emptying. So pretty much all it's saying is, all this is where if you have a central nervous system dysfunction, whether it's spinal cord injury from a wreck or whatever that may be, you could have where your bladder has these extra contractions that causes you to void. You could also have a flaccid bladder dysfunction, which is underactive. This usually occurs when there's damage at the level of the sacral spinal cord. Let's see. The flaccid bladder dysfunction usually occurs from spinal shock, from a spinal cord injury. You could also have some peripheral neuropathy that's generally caused from diabetes. As you know, diabetes is very popular in our patient population. Usually your clinical manifestations, the patients will come in for lower abdominal pain as well as new onset of incontinence. Some of the tests that they might order, that your docs might order, if there's any diagnosis of spinal cord injury, they will go ahead and look into both of these. They could do a urine culture to see if you're growing anything, a UA. Your creatinine and BUN will also be treated. Then they can also do a post-void cath, which just means they would have the patient to urinate, and then we would straight cath. If there is greater than 150 mLs, then that might indicate an ineffective muscle tone. Medical management, of course, there's some medications that can be given for that. Bladder retraining, where the patient would have to go to the bathroom every hour. Education, would focus on things like nutrition. You want to make sure they're drinking enough water, make sure they stay away from foods that might cause renal calculi. You could also, the patient might go to surgery. Let's see. Next is urinary incontinence. So we have several types here. You have stress, urge, overflow, functional, mixed, and total. Urinary incontinence is just the involuntary action of urination. Maybe when you cough, maybe you don't even have to be doing anything. You just have your incontinence, just sitting in a chair. It does affect at least 17 million people in the United States, 30% of older women. It occurs in 50% of your older persons living in long-term care. Let's see. It can be from congenital causes. It can be from irreversible causes like spinal cord injury, MS, stroke, Parkinson's. It could be from reversible acute causes, something that we can treat. It could be UTI. Some of the medications can cause that. In males, it could be from an enlarged prostate, or it could also be from fecal impaction. So that's all things that you need to keep in the back of your mind. Why do you think a fecal impaction could cause urinary incontinence? So some of your types: stress. This is a loss of urine due to pressure applied. It's more common in women. Lifting, coughing, sneezing. Urge. This is a strong urge to void precipitates involuntary loss of urine. This is usually seen more in the elderly. They just can't make it to the bathroom in time. Overflow is just an inability to empty the bladder. It leads to distension and frequent loss of small amounts of urine. So they're not completely emptying their bladder, just a little bit of urine is lost at a time. Functional. This is from physical, environmental, or psychosocial causes, which could be from catheters. It could be from several different things. Let's see. Mixed is a combination of stress and urge. And then total is loss of all voluntary control. You have a continuous leakage of urine. This all causes an increased risk of falls, fractures, pressure injuries, UTIs, and of course depression. Why do you think it would cause an increased risk of falls and fractures or even depression? Think about what that would do to you if you become incontinent at an early age. So some of the diagnostic tests, you want to think back to those slides that we went over for UA. They can do an ultrasound or a cystoscopy procedure. Your post-voiding residual, you'd want less than 50 mLs after your patient voids. There is medical management for urinary continence depending on what the cause is. It may be that they have to have surgery to fix an obstruction, bladder repair. It may be that the prostate has to be shaved down. For nursing interventions, some things that you can teach is your Kegel exercises, teach your dietary and fluid intake. Your bladder training is also a good one for the nursing interventions. The urinary tract infection, this is the second most common bacterial disease. In healthy people, urine in the bladder is sterile, so no bacteria or other infectious organisms are present. The urethra contains no bacteria, and however, any part of the urinary tract can become infected, which is called a UTI. It's usually caused by bacteria, but can be viral, fungi, or parasites. If it's a urethral infection or bladder or kidney infection, that is what's referred to as a UTI. Think about some of the reasons that a female might be more susceptible to a UTI versus a male. These are different symptoms, tests, as well as interventions. Think about what happens in your geriatric population when they may have a UTI. This is just inflammatory conditions, your patients will have all of these symptoms if they have any of these. So make sure you know these. Your pyelonephritis, a common cause of that is E. coli. That's important to know. And that is the end. Once again, if you have any questions, make sure you email me. If I have misspoken or confused you in any way, please email me. And make sure that you guys are utilizing your extra resources that will be uploaded to Blackboard. Thank you.